Hello, welcome to BJK-NEET&MED. In this video, I am going to discuss about scalp, which is a topic from anatomy, head, neck and brain. First of all, let's see the extent of scalp. Let us consider this as anterior and this becomes posterior. If we see the extent, the blackly marked one here is the scalp. So it extends anteriorly till superciliary arches. This is the anterior extension. So scalp extends anteriorly superciliary arches. If we see posteriorly, it extends till superior nuchal line. So extent of scalp posterior is superior nuchal lines. If we see laterally, scalp extends laterally till superior temporal line. So lateral extent of scalp is superior temporal line. Extent of scalp anteriorly superciliary arches, posteriorly superior nuchal lines, laterally superior temporal line. Let's see the layers of scalp. Scalp itself is the mnemonic to remember the layers of scalp. S stands for skin, C stands for connective tissue, A stands for aponeurosis, L stands for loose areolar tissue and P stands for pericranium. Let's see them. S stands for skin, C stands for connective tissue, also known as superficial fascia. A stands for aponeurosis. Here, aponeurosis also contains a muscle known as occipitofrontalis muscle. Next, loose areolar tissue. Last layer is pericranium. Let's see the diagram of scalp. In the layers of the scalp, first of all skin, next connective tissue, next aponeurosis, loose areolar tissue, pericranium. These are the layers of the scalp. Below the pericranium, there is bone. This is the bone, and below it there are sinuses. After that, brain is present. Layers of the brain and meninges and brain is present. This is the superior sagittal sinus and falx cerebri. This is a dural fold, and there are some other parts like hair. Always in anatomy, nerve is denoted drawn by yellow color, artery by the red, vein by the blue color, and this is the emissary vein, this is diploid vein, and that is a diploid. Let's discuss briefly about each and every layer of scalp. First layer is skin. Skin is thick and hairy except over the forehead. As we all know that scalp extends till forehead. It also includes the forehead region. But we are very aware that forehead doesn't have hair. Hence, the scalp area over the forehead doesn't bear hair. So, as the skin is very much hairy, it has many hair follicles. So, as there are the many hair follicles, there are many associated sebaceous glands. Hence, scalp is the commonest site for sebaceous cyst. This is the applied aspect of the skin layer of scalp. Sebaceous cyst is the commonest site for one of the commonest site, as the skin possesses many sebaceous glands. Along with sebaceous glands, skin of scalp also has numerous sweat glands. Next layer of scalp is connective tissue, also known as superficial fascia. The superficial fascia of scalp is made up of dense fibrous connective tissue. Hence, the layer is also known as connective tissue. If you see, the fibrous connective tissue is firmly adherent to the above layer skin and below layer aponeurosis. So, it attaches firmly to the above and the below layers. Next, this superficial fascia is made up of many lobules of the fats, which are divided by the fibrous septa, and they enclose blood vessels and the nerves. We can see clearly. Here, nerve, artery, and vein are present in the connective tissue layer. Then there is one applied aspect of connective tissue that is known as profuse bleeding. If we see profuse bleeding, if any of the blood vessel in the connective tissue layer of the scalp is damaged, it profusely bleeds because the blood vessels cannot retract after damage of the blood vessels, because the blood vessel walls are adherent to the fibrous layers of the connective tissue. That is the reason why profuse bleeding occurs when the blood vessels damage in the connective tissue layer of scalp. In order to prevent the profuse bleeding because of the damage to the blood vessels in the scalp, we have to apply pressure against the blood vessels, against the bone present to it. Next layer of scalp is aponeurosis. As we earlier discussed that aponeurotic layer has aponeurosis, along with that it has muscle layer that is known as occipitofrontalis muscle. If we see occipitofrontalis muscle, it has 4 bellies, 1, 2, 3 and 4. 4 bellies are present. 2 bellies are frontal and 2 are occipital. Frontal are present anteriorly, occipital are present posteriorly. If we see, this is the nose, so it is anterior, this is posterior. These two are ears, so those are present laterally. So frontal bellies are present anteriorly, occipital bellies are present posteriorly. The green color one is aponeurosis. The aponeurosis here is known as epicranial aponeurosis, or it is also known as Galea aponeuretica. In Latin, Galea means helmet. So it somewhat resembles like helmet. It is also known as Galea aponeuretica. It is also known as epicranial aponeurosis. If we see, this is the third layer, which is majorly formed by aponeurosis enclosing muscles. It has 4 bellies, 2 frontal bellies and 2 occipital bellies. We have one applied aspect of aponeurosis, that is, if any wounds occur in the skull, if we consider 2 possibilities, like one as a transverse and one as the vertical. As the bands of the aponeurosis and the muscles are extending from the anterior to posterior, if we see vertical extensions, if the wound occurs vertically, there will be no gapping occur after healing. If the wound occurs transversely, the fibers get distorted. That is the reason why wound may appear as gap after healing. This is the applied aspect of aponeurotic layer of scalp. Fourth layer of scalp is loose areolar tissue. If we see, this is a loose tissue which is formed by the loose areolar tissue. That's simple. If we keenly observe, loose areolar tissue is traversed by emissary veins. These emissary veins connect second layer of the scalp connective tissue with the intracranial dural venous sinuses. Here specifically mentioned as in this diagram superior sagittal sinus. Next, there is one applied aspect for loose areolar tissue, that is loose areolar tissue. It acts like natural plane of cleavage during craniotomy. In order to, while doing the surgeries on the scalp, this layer acts like the natural plane of cleavage. Means this layer, if we pull these scalp layers apart, this layer will come easily, because if we consider above 3 layers, these 3 layers are very compactly intact with each other very tightly. They cannot come out easily if we try also, but this layer will come out very easily if we pull out. So hence loose areolar tissue acts like natural plane of cleavage during craniotomy. Last layer of scalp is pericranium. Pericranium, below the pericranium, bones of skull vault are present. So cranial bones are present below pericranium. Pericranium and bone of cranial vault are loosely attached except at the suture. Pericranium is formed by the periosteum of the bones of the cranial vault. Let us see briefly about occipitofrontalis muscle. As we already discussed about this, as your nose is present, this is anterior side and this is posterior side. These are ears, so these are lateral. Anteriorly, 2 bellies are present, those are frontal bellies, and posteriorly another 2 bellies are present, occipital bellies. Hence the muscle layer is known as occipitofrontalis muscle. Occipitofrontalis muscle lies in the aponeurosis known as the epicranial aponeurosis. It is also known as galea aponeurotica. In Latin, galea means helmet. And this aponeurosic layer is the third layer of the scalp after skin and connective tissue. Then, if we see briefly about the frontal bellies, any muscle discussing in the anatomy, we have to look about 4 things. Those are origin, insertion, nerve supply, and action. These are very important things. If you want to know about anything of the muscle, you have to know at least origin, insertion, nerve supply, and action about that muscle. So let us simply look about this occipitofrontalis muscle under these headings. Origin. Let us see the origins of the frontal bellies. Frontal bellies origin from the skin and subcutaneous tissue over eyebrows and the root of the nose. So origin of frontal bellies are skin and subcutaneous tissue over the eyebrows and the root of the nose. That's it. Where they insert, those fibers arise from those area and run backwardly and upwards, and they insert in the epicranial aponeurosis. If we think of the occipital bellies, the origin of the occipital bellies is lateral 2/3 of the superior nuchal lines, and the insertion, actually these fibers run forward and upward and they get insert into the epicranial aponeurosis. So when we think of these 2 bellies, the insertion is common, that is epicranial aponeurosis. That is reason why they are considered as a single muscle, that is occipitofrontalis muscle. Next, let's compare these 2 bellies. When we think of the frontal bellies, those are long and wide. They are partly united. When we think of occipital bellies, those are small and those are far away, and those have the considerable gap in between them. Let's think of the nerve supply. As we can see in the diagram, the frontal bellies are supplied by temporal branch of facial nerve when we think of the occipital bellies, those are supplied by posterior auricular branch of facial nerve. Next, action. The alternate contractions of frontal and occipital bellies, it will makes the scalp to move forward and backward. And frontal bellies has other two actions like acting from above and acting from below. If the action is from above, the contraction of the frontal bellies will leads to the rising of the eyebrows as in the surprise. If the contractions are from the below, the frontal belly's contractions leads to the transverse wrinkles on the forehead as in the fright. These are the actions of the muscle. We can think of the more points about occipitofrontalis like origin of the frontal bellies has the deeper fibers originating will merge with other muscles like procerus, corrugator supercilii and orbicularis oculi muscles. An insertion we can specifically mention for the frontal bellies like it insert into the epicranial aponeurosis just in front of the coronal suture. There are majorly three clinical correlations of scalp. First one is surgical layers of scalp. Second one is dangerous area of the scalp. Third one is black eye. First one, surgical layers of the scalp. First three layers of the scalp are called as scalp proper. Those are known as the surgical layers of the scalp. SCA means skin, connective tissue and aponeurosis. These three are tightly bound to each other. Hence these are known as surgical proper, scalp proper or surgical layers of the scalp. Because when during the surgery, when the scalp is removed, these three layers will combinedly come each other. Next one is the dangerous area of the scalp. Loose areolar connective tissue layer is known as the dangerous area of the scalp because as it is very loose, when there is a major chance of the accumulation of the blood or the pus in that layer. If the pus accumulation occur in that layer, the infection may spread into the brain also through the sinuses. That is reason why loose areolar tissue layer is known as the dangerous area of the scalp. Black eye. Black eye occurs due to the accumulation of the blood in the loose areolar tissue around the eyelids areas. It actually occurs due to the severe blow or the trauma in the head region or during the fist fighting around the eyelids. Next topic is nerve supply of scalp. It includes sensory nerve supply of scalp and motor nerve supply of scalp. First of all, sensory nerve supply of scalp. In sensory nerve supply of the scalp, these two are auricles. So, if we divide head into two regions by the midline, anterior posteriorly, let us consider only one half. One half of the scalp is supplied by 8 sensory nerves. In that 8 sensory nerves, 4 are in front of auricle and 4 are behind auricle. The sensory nerves which supply scalp in front of auricle are derived from fifth cranial nerve known as trigeminal nerve. Next, the sensory nerves which supply scalp, which are 4 in number behind the auricle, are supplied by cervical nerves. means spinal nerves which are derived from the cervical segments. If we consider trigeminal nerve, it has three divisions like V1, V2 and V3, means fifth cranial nerve has three parts. First division, second division, third division. First division is known as ophthalmic division. Second division is known as maxillary division. Third division is known as mandibular division. First two nerves are branches of ophthalmic division. Third nerve is branch of maxillary division. Fourth nerve is branch of mandibular division. So let us see the names of them. What are the four sensory nerves which supply scalp, which are present in front of auricle, are supratrochlear, supraorbital, zygomaticotemporal and auriculotemporal nerves. Supratrochlear nerve is a branch of frontal nerve which is a branch of ophthalmic division of trigeminal nerve. Supraorbital nerve is also a branch of frontal nerve which is the branch from the ophthalmic division of trigeminal nerve. Zygomaticotemporal is a branch of zygomatic nerve which is a branch from the maxillary division of trigeminal nerve. Auriculotemporal is a branch from the mandibular division of the trigeminal nerve. When we think of the nerves which are present behind the auricle or great auricular, lesser occipital, greater occipital and third occipital nerves. Great auricular nerve or C2 C3, lesser occipital C2, greater occipital C2, third occipital C3. First two nerves are derived from the ventral rami, whereas next two nerves are derived from the dorsal rami. Motor supply of scalp. The motor nerve supply of the scalp is same as that of the nerve supply of the occipitofrontalis muscle, because occipitofrontalis muscle is the only muscle present in the layers of the scalp. Hence motor supply remains the same. Hence motor supply of the scalp are two nerves. Two nerves are in front of the auricle, two nerves are present behind the auricle. There are the pair of the temporal branch of facial nerve in front of auricle, and there are a pair of posterior auricular branch of the facial nerve behind the auricle. Temporal branch of facial nerve supplies frontal bellies of occipitofrontalis muscle, whereas posterior auricular branch of facial nerve supplies occipital bellies of occipitofrontalis muscle. Blood supply of scalp. Blood supply of scalp includes arterial supply and venous drainage of scalp. In the arterial supply of the scalp, there are 5 arteries present on the off of the scalp. Means total scalp is supplied by the 10 arteries. If we consider only one off, in front of the auricle there are 3 arteries, and behind the auricle there are 2 arteries. The arteries which are present in front of the auricle are supratrochlear artery, supraorbital artery, superior temporal artery, posterior auricular artery and the occipital artery are present behind the auricle. Supratrochlear artery and the supraorbital artery are the branches of ophthalmic artery, which is a branch of the internal carotid artery, whereas rest all arteries are the branches of external carotid artery, and superior temporal artery is the smallest terminal branch of the internal carotid artery, and soon after it entering the scalp it divides into anterior and posterior branches. Supratrochlear artery enters the scalp around the supraorbital region, around just one thumb lateral to the midline, whereas the supraorbital artery enters the scalp through the supraorbital notch, which is present in the skull, and it is present 2 to 3 centimeters lateral to the supratrochlear artery. And posterior auricular artery enters the scalp from the root of the ear, whereas occipital artery enters the scalp way between the ear and the external occipital protuberance. If we observe the arterial supply of the scalp, there is a lot of anastomosis occurring between the arteries. The anastomosis is occurring between the arteries of the same side and also with the other side also. Hence, scalp is the potential site for the collateral circulation of the internal and external carotid arteries. Venous drainage of scalp. As like arterial supply of the scalp, venous drainage of the scalp is also done by 5 veins. The names remains the same. Supratrochlear vein, supraorbital vein, superior temporal vein, posterior auricular vein, and occipital vein. Then where here supratrochlear vein and supraorbital vein combines to form angular vein at the medial angle of the eye. When we think of the superior temporal vein, it ultimately drains into internal jugular vein. Whereas posterior auricular vein terminates ultimately drains into external jugular vein. Occipital vein drains into suboccipital venous plexus. Supratrochlear vein and supraorbital vein combines to form angular vein. Superior temporal vein ultimately drains into internal jugular vein. Posterior auricular vein ultimately drains into external jugular vein, and occipital vein drains into suboccipital venous plexus. There are plenty of the veins formation in the superior temporal vein, between the superior temporal vein and the internal jugular vein, and posterior auricular vein and the external jugular vein. But we look them in the parotid region as they are complex here. The veins of the scalp communicate with the intracranial dural venous sinuses through emissary veins, as you already seen in the layers of the scalp. Thank you for watching this video. Like, share and subscribe.